Thank you very much. I'm Marco Ranieri from the University of Bologna, and thank you very much for having me with you today. Prone position is one of the intervention we have in the management of patients with ARDS that are clearly allocated in the flow of intervention we should perform. This is one of the paper published by the Berlin Definition Network, where treatment available for ARDS were allocated in this graph, where you see on the vertical axis the increasing intensity of the intervention, and the horizontal axis the severity of ARDS quantified by PF ratio. And you see that prone positioning is quite high in the vertical scale, implying a substantial complexity from the procedural standpoint, and is allocated at the extreme of the severity scale expressed as PF ratio. But the color code is blue. And in this slide, color code blue indicates intervention that are strongly supported by evidence. So prone position, although is relatively complex and although limited to the most severe form of ARDS, must be used in this patient population. So what is the rationale for this intervention? Is, as proposed originally by Luciano Gattinoni several years ago, the distribution of edema in ARDS follows the so-called sponge model, where you have the gravitational pressure that is superimposed to the lung structure, causing interstitial edema, increased mass, and collapse to be preferentially allocated in the dependent zone of the lungs. Now, again, going to the original description of Gattinoni, you see that the gas-Tis ratio is a sort of functional distribution based on lung height. And this is true either in the normal condition, when you see this vertical distribution in supine, that is attenuated, flipping the normal subject in prone. The same behavior is overexpressed in patients with ARDS, and therefore the potential efficacy of prone positioning in normalizing the distribution of lung edema, in re-establishing an homogeneous gas to tissue ratio, is more enhanced than in normal subject. And here you have the distribution of lung edema going from supine to prone, back to supine, using the CT scan analysis. Now, all this is a strong physiological rationale for the use of prone positioning in patients with ARDS, but it's interesting to see how long did it take to go from a strong physiological rationale to solid and duplicated clinical evidence. This is the first randomized control trial that was conducted several years ago by Luciano Gattinoni's group, that was the group that developed the physiological background for the study. And in patients with, at that time, it was called severe acute lung injury, there was no difference, no statistical difference in terms of survival in patient randomized in the prone positioning or in patients treated in the supine position. The post hoc analysis of this study show that prone positioning reduced mortality in patients that had the most severe form of ARDS, identified by a PF ratio lower than 88. Now, a second randomized control trial, published in 2004 on JAMA, was conducted by Claude Guérin. And again, no significant difference in patients randomized to supine or prone position. More important, in this study, it was systematically observed a substantial number of side effects, more specifically unplanned extubation, selective intubation, that means the dislocation of the ET tube during the prone position, and obstruction of the endotracheal tube. Prone position was applied in less than 8 hours, and only 50% of these patients had acute lung injury as it was defined at that time, or ARDS. And there was a substantial number of patients, 21%, that had a crossover between interventional and control group. So in the 2000, early 2000, the evidence were not supporting the use of prone positioning. There was no difference in terms of survival. Ventilatory strategy had nothing to do with protective ventilator protecting ventilatory strategy. The studies were small. Proning was applied for a short period of time, and not all of patients were characterized as having ARDS. Again, in 2009, now we're approaching the 90s, the new millennium. Again, a randomized control trial performed by Luciano Gattinoni showed in the entire population no difference between prone and positioning. However, for the first time, using the information that were acquired in all these previous randomized control trials, it was possible to see a trend in terms of a significant effect in terms of improvement of survival in patients with the most severe form of ARDS, characterized by more severe hypoxemia, while no signal in patients with moderate hypoxemia. And with this idea, a meta-analysis, an individual patient meta-analysis was performed. And this is one of the examples suggesting how clinical research, a strong methodology applied to clinical data can actually be important in terms of clinical management. In fact, this individual meta-analysis showed that, again, in the entire patient population included in all these randomized control trials, there was no difference whatsoever in terms of survival between prone and supine. However, in patients with severe hypoxemia, and now at that time we had a very long discussion on how severe had to be severe hypoxemia, there was a significant improvement in survival. And this led to the fact that in 2013, we were able to see published in the New England Journal of Medicine, finally, a paper that included patients with severe ARDS, defined as a PF ratio lower than 150, that put it prone had a substantial and significant improvement in survival as compared to patients in the supine group. So what was the reason why this study, the PROSEVA study, finally ended up with such a strong positive signal in favor of proning patients? Because it included patients with the most severe form of ARDS, PF lower than 150. Pronation was applied early on in the clinical course. Pronation was applied for at least 12 hours and was discontinued in all the patients who did not respond in terms of improvement in oxygenation. So this is the rationale why we, the Berlin Definition Group, put the color blue to indicate that, to prone positioning, indicating that this is a procedure that must be applied in patients with ARDS. So what are the key questions that clinicians should take into consideration while deciding to put patients on prone position? First of all, the appropriate indication, so to identify the patients that actually do need prone positioning and actually do respond to prone positioning. The second question is for how long prone positioning should be applied, and therefore evaluate physiological variables that are easily applied at the bedside that can tell us if the patient is or is not responding to proning. And you should always take into consideration that this is an intervention that may have potentially adverse events. So what is the appropriate indication? Severe ARDS. The physiological response we should look at to identify responder and non-responder is an improvement in oxygenation. What are the adverse events you should take into consideration? First of all, lesions to the faces, to the patient's face, because of the increased pressures on tissues caused by the proning, increased obstruction of endotracheal tube, and all others complications that are related to the airway management and to management of vascular access and catheters. So always remaining on the key questions. uh, Effects on oxygenation must be kept into consideration. However, we always have to keep in mind that by proning the patients, we alter the distribution of shunt and dead space. And we always have to take into consideration that we may have effect on respiratory mechanics, and we may have effects on hemodynamics. And we should also take into consideration that proning the patient, we may modulate the impact of mechanical ventilation in terms of ventilator-induced lung injury. Now, let me focus on this aspect because this is something that appeared clearly in the scientific literature. Now, by changing the patient from supine to prone, we are not just causing a more homogeneous distribution of volume and blood flow, and therefore we are causing an improvement in gas exchange, in oxygenation mostly. We are redistributing gas volume in a way that the lung is more homogeneous, and therefore the potential effect in terms of ventilation-induced lung injury of tidal volume, inappropriate tidal volume, and inappropriate levels of PEEP is minimized. So one of the potential benefits that was underestimated in the original studies of proning patients is to reduce ventilator-induced lung injury. Another element that should be taken into consideration is the hemodynamic effect of proning. And this is a very nice echo images showing the effect on right ventricle unloading of proning the patients. All these aspects were so important in defining the reason why prone positioning was effective that in this review article published by Rick Albert in the Blue Journal in 2014, it was suggested that prone positioning is, yes, an intervention that should be considered for patients with severe hypoxemia and indicated for patients with a PF ratio lower than 150. But an important piece of this editorial is that the positive effect is not just related to the improvement in oxygenation, but to the efficacy of prone positioning in reducing ventilator-induced lung injury. Let me stress again the importance of side effects that we should consider in prone positioning. The displacement of the ET tube, the displacement of the chest tube if it's present, the loss of catheters and other intravascular devices, obstruction by secretions. And these are related to the changes in position. Related to prone position itself, pressure ulcers, facial of edema of the eyes, vomiting, and a reported increased need for sedation. Contraindications are very few: burns, open wounds, spinal instability, unstable pelvic fractures, severe hemodynamic instability, late pregnancy. Nevertheless, the intervention has been clearly shown to be effective in saving life of patients with ARDS, but still several case series show that is used in relatively few patients. So 16% of severe ARDS in this case series from Europe, 33% in severe ARDS in a following case series. Now, is that because there is in general a barrier to apply evidence-based medicine intervention? I don't think so. Prone positioning remains an intervention that should be considered complex, that should be considered time-consuming, personal consuming, and with important side effects. Let me share with you some of our clinical images of patients with severe ARDS in prone positioning. Here you have the system we used. This is a self-made system to avoid lesions to the face of the patients. Note the particular care that was paid in managing the vascular access. Everything had to be clear. It looks like a sailing boat where you have to see the ropes that allows you to control the boat. Here, note the upper and lower limbs positioning, and note that prone positioning can be implemented in patients with extracorporeal support. This is a patient on VV ECMO, or in patients with renal replacement therapy. And again, look how complex can be to put a patient on prone positioning, and trying to imagine the workload that was required to put the patient in this position in terms of nurses and doctors. In our institution, you have one doctor that is full-time dedicated to the control of the head, and another doctor that is supervising the flipping, and we have at least 3 nurses that are involved in the change in position of the patient. Again, another example of patients in prone position during ECMO. And let me briefly conclude with some images, some data regarding the use of prone positioning in patients with COVID-19 induced ARDS. Now, ARDS is a common disease, is a common syndrome, is not anymore a rare syndrome. And as a matter of fact, prone positioning was used to improve oxygenation in patients not responding to conventional mechanical ventilation. And in a way, given the impact, was a sort of alternative of ECMO. This is one of the several series we see it as effective prone positioning was in patients with ARDS. It's interesting to see that there was a responder versus non-responder trend distribution and in patients with COVID-19 induced ARDS. But I want to conclude with 2 studies that were extremely interesting, I believe, in the very early days of COVID-19. And it's the use of prone positioning in patients with non-invasive ventilation. And you see how, if you look at oxygen saturation, PF ratio, and respiratory rate, that the use of proning was associated to a significant improvement in oxygenation and a reduction in respiratory rate, so making non-invasive ventilation more effective. And again, as the previous series of data obtained in patients intubated and on invasive mechanical ventilation, also in patients in non-invasive ventilation, it was possible to see patients who did respond to prone positioning in patients who did not respond to prone positioning, duplicating therefore also in non-invasive ventilation what we saw on invasive ventilation. Can we predict this? It's very difficult to say. And at the time, we don't have data to go along in this direction. These are preliminary data that we obtain in our case series, the paper is submitted. And again, you see that PF ratio, the response in terms of oxygenation, in terms of in patients with COVID-19 induced ARDS, is not always consistently associated to an improvement in oxygenation. Thank you very much.